Okay, to continue on that topic, now we'll have Dr. Lucy Roche come up. She's an associate professor of medicine at the Toronto ACHD program, University Health Network in Toronto, Canada. And she'll also be talking on heart as a single organ transplant versus heart-liver combined transplant.
Thank you. Thank you so much for the invitation to speak today. It's really nice to join you and be part of this conversation. I have no disclosures. When I got given the topic of this, I felt this sounds like more of a debate, and which I'm supposed to give both halves. So that's how I'm going to approach it today. I'm going to debate the whole of the first half and then try and use similar data, because there's only so much data we can use here, and it's the same whichever half of this you're debating, and debate the other half. So I'm going to start with assuming that combined heart-liver transplant is the ultimate therapy, as the paper says, for Fontane's circulatory failure. And I'm going to give you 3 arguments why I'm definitely correct about that. And I'm sure you're all going to agree. And as we've already heard today several times, the first of these arguments is that by the time Fontane's circulatory failure warrants heart transplant or heart-liver transplant, Fontane-associated liver disease is ubiquitous. And then the second argument is that Fontan-associated liver disease causes perioperative catastrophe after heart transplant alone, and several people have alluded to that. So I feel I'm on kind of solid ground with these arguments. And thirdly, I'm going to show you some data hot off the press that combined heart and liver results as superior, and therefore I think this will be conclusive for you all. So let's talk about the first of these. So this is a mixed audience of pediatric and adult congenital cardiologists, and I'm actually a pediatric cardiologist by training who now only does adult congenital heart disease. But really, in childhood, severe Fontan circulatory failure has become unusual. This is data from the Hospital for Sick Children in Toronto, which looked at all of their Fontans after 1985 in patients who'd had either an extracardiac or a lateral tunnel Fontans. There's 500 patients. And they divided it into 2 eras, and you can clearly see there was such an improvement in outcomes, and that since 2000, there's been no deaths. There may have been after this, I don't know, but between 2000 and 2012, there were no deaths before hospital discharge after Fontan completion. And since 2000, the late deaths were only 14 and 4.6%. So even if we were to think about transplanting these patients, there's very few in childhood that would need this, and mostly because we've discussed several times all the comorbidities of Fontan patients and the pathophysiology that continues after Fontan completion. This is something that adult patients will inevitably face, and the decisions will really become the realm of the adult congenital cardiologist. This paper looked at Fontan-associated liver disease surveillance in childhood, looking at repeated liver ultrasounds and laboratory data, and found that the prevalence of Fontan-associated liver disease and severity increased. And other people have shown similar data, but by the time these patients are 10 years after Fontan completion, 2/3 of them have moderate to severe, and they scored it in a way with points for each of these things, Fontan-associated liver disease. So you can see that by the time these patients reach adulthood, when we're talking about transplanting them, they're all going to have at least moderate, and a big chunk of them, probably more than 1/3, severe Fontan-associated liver disease. So it makes sense that we consider transplanting that liver in these patients when we come to talk about transplant. The reason it's important that they have Fontan-associated liver disease for us when we're thinking about transplanting them is that it really causes and drives these horrible early post-operative outcomes that people talk about after heart transplant alone. Dr. Hickey talked about some of this. These are intensely challenging transplants. You have to think about how you're going to get into the heart. These are some of the patients we've considered for transplant. You can see that this massive RA is right behind the sternum. You have to do PA reconstruction, aortic reconstruction. You all know that these patients have collaterals. They've been mentioned several times today. Patients are sensitized. Sometimes you're taking hearts from a long time away and you can't control the ischemic time, and there are problems with vasoplegia and all the other organ dysfunction. So when you've got this intensely challenging transplant, why do you want to add to it this liver that may not function very well afterwards when you know the liver's impaired? And the reasons, the ways in which the liver contributes to post-operative mortality is in part because of bleeding. And I've borrowed these slides from a colleague who I heard present this half of this argument a while ago, and we know that Fontan-associated liver disease, through many mechanisms, increases bleeding post-transplant, decreases the ability for the blood to clot. And the bleeding causes RV dysfunction and multi-organ failure, and eventually results in death in the perioperative period. This is the role of bleeding in this has been confirmed by this paper, which is probably from, I'm going to refer to this paper a few times because it's probably the largest single-center adult heart transplant only data. And they looked at patients between 2007 and 2019, and they found in various ways of looking at it that the biggest predictor of poor outcome in the perioperative period post-transplant were patients who had major bleeding during the operation, during the heart transplant operation. And the moral of this story is that if you could find a way to stop them having major bleeding, then you would put them on this curve, which would give you a very much better post-transplant survival. And I would posit that one way to stop the post-operative bleeding problems is to transplant the liver, because that's where the bleeding is often coming from. And then the third argument that I'm going to talk about is that combined heart and liver results are superior, not just for that early post-operative period, but also for late outcomes. We've heard today, and I'm not a hepatologist, so I can't explain this in depth, and again, I borrowed the slide from Justina, that the liver plays an important role in immunological function. And if your liver is functioning well, it probably decreases the risk of sepsis and rejection. And these are both things which we heard in an earlier speaker today drive post-transplant outcomes in Fontan patients. The highest risks of death are from, the biggest causes of death are from sepsis and rejection. So in some way, if you have a liver that's able to do these things and able to control this, you might produce better long-term outcomes. This has not clearly been studied in long-term follow-up, but it makes a lot of sense. And there is also potentially a role for improving late outcomes, particularly in sensitized patients, if you have an immune function that's working quite well. All of this is summarized in this slide, which is the AHA white paper on Fontan-associated liver disease, and summarized very well here. You've seen the picture before, but it really is just arguing the difference between if you're going to do a heart transplant alone, you have to consider what are the potential outcomes. So this fibrosis could regress, it could progress to cirrhosis. We've mentioned before that some of these patients are at risk of hepatitis C. If you leave the liver in place, presumably these patients remain at risk of hepatitis C in the long term, and that there is the risk of post-operative hepatic decompensation. So if you consider a combined heart and liver transplant, you get rid of some of these risks. Obviously, you don't have to worry about the development of progression and the development of hepatocellular carcinoma. And you also get these extra added benefits of the immunological benefit. So even without this new data that I'm going to show you, which is hot off the press, published this week, I think I'd have a pretty strong case for saying that heart-liver transplant is the best option for patients with a failing Fontan circulation. But just to add to that, lucky for me, presenting this side of the debate, this was published this week. And this is data from 15 US and Canadian centers looking at patients who'd undergone heart or heart-liver transplantation and comparing the outcomes. There was 131 patients, which was 91 heart transplants and 40 combined heart-liver transplants. All of the patients were over 16 years of age. The team gave a score, 1 point for any of these things. We've talked about it's difficult to know how bad is Fontan-associated liver disease. And lots of people today have tried to put up scores and shown other papers, but in this one, they gave a point for having had more than 2 paracenteses, imaging or pathology-based cirrhosis, splenomegaly, or varices, and that to me sounds a reasonable way of scoring it. I'll show you some other data from this paper later. The overall results were kind of similar, but if you look at the patients who have a high liver score, and you look at the patients who were transplanted after 2000, which is the more recent kind of era when more heart-liver transplants were done, you can see a clear preferential outcome for patients who had combined heart-liver transplant. So I really think that this is the nail in the coffin for the other argument, and I can't see how that anybody would disagree with the proposition that combined heart-liver transplant really is the ultimate treatment for Fontan circulatory failure. And if I was doing a debate, this is where I would rest my case. However, I'm going to take my cardigan off and present the other side. So here we go. Pretend I'm somebody else now. And I'm going to present that I think combined heart-liver transplant is rarely required for spontan circulatory failure. And in fact, heart transplant is the preferred option. And I'm going to, obviously, the person presenting before me had 3 great arguments, but I'm going to take those apart, and I'm going to replace them with arguments that show that this is the definitely correct statement, and this time I know I'm going to win, and you're all going to agree with me. We'll have a vote at the end, not really. Okay, so before I start my talk, I'm thinking about who might disagree with me, because when I'm trying to give a talk, I'm trying to win those people over. And unfortunately for me in this audience, there's quite a lot of US centers. And the first time I ever print this, I had some, and now I've put many. US centers probably disagree with me. Originally, it was just a couple of places. And you can see that these people's websites and papers say things like Fontan patients deemed eligible for single heart transplant will all undergo a dual organ transplant. And other people think it's the ultimate treatment option, like the person who argued before me. And even here, Sasha, who is in the audience, his website says now that these patients whose best chance at long-term survival is with combined heart-liver transplant. And this is the kind of thing our patients can read when they're trying to find out about this. Unfortunately for me, well, not unfortunately, this message has come along and people are really taking to it, and there has been increased use of combined heart-liver transplant in the US in recent years. And you can see this paper here showing a much bigger number of patients. So this is 50 per year in patients from 2011 up to 2020. And you can see that the era-related changes relate to the diagnosis. So in the more recent era, the primary diagnosis now for combined heart-liver transplant in the US is congenital heart disease. And then this hot off the press thing makes it even more clear. This is a United States paper, obviously, and shows that survival rates are better. So I really think that you are a tough crowd for me, making the opposite argument of this, but I'm going to do my very best to take down these 3 arguments, which I think are completely incorrect. And I'm going to start with this one. Well, actually, it's not incorrect. It is ubiquitous, but I don't think that that's the point. So yes, I agree that Fontan-associated liver disease is ubiquitous in adult life, but that's not the point at all. More importantly, how many people are living with this Fontan circulation? And this is a paper which is quite interesting. It starts out with a real number. They actually counted in, I think it was the UK, Australia and New Zealand and the US, how many patients are alive with a Fontan circulation at the moment. And it's 66 per million in 2020, 55% are adults. And then they did a prediction of how many there will be. And you can see it is mostly adults now that are living with this circulation, and there's 77 people per million. So yes, all of these people have Fontan-associated liver disease, and at some point, many of them are going to need a heart transplant. They may not all be eligible for a heart transplant, but they're going to need one. Just looking at Canadian data, I can't find this data for the US, but if we think that we're going to give them all a heart-liver transplant, what will that actually mean? Well, looking at the waiting list in Canada, you can see that people waiting for a liver transplant last year, of the people on the waiting list, 95 died without a liver transplant. So if we're going to start adding to this 77,000, it won't be all of them at once, obviously, but a large number of Fontan patients who we're going to try and take the livers from these patients, this number is going to be much higher. So we're really talking about something that I think is the most important thing when we think about who needs a transplant. It's not that you have Fontan-associated liver disease that means you need a transplant. We have to go back to our medical ethics training 101 and think about how do we make a decision about the best action to take. And we have to think about doing good and not doing harm and what the patient might want in this situation and ensuring fairness. And then this is something that we can think about. You maybe did this experiment at university where you have a trolley car and you get to make these thought decisions about, are you going to pull the lever and let the trolley car go this way or that way? And they make it harder and harder to, are we going to do the greatest good for the, what is it called? The utilitarianism, the best increase in utility, the best for the most number, or are we going to try and help 1 or 2 people? And this definitely plays a role in this, because some of these patients, if we take these livers for our Fontan patients, there will be other patients who die from liver failure who do not have an organ replacement therapy. We've heard here that VADs potentially can be used for Fontan patients. There isn't a VAD, I don't think, for a liver that's failing or something like it. And I don't think so. So I'm going to replace this argument. I think that this is it's true, but it's not actually an argument, and I'm going to replace this with utility. And this, I found that you actually used to have trolley cars here in Pittsburgh. We still have them in Toronto. Just to remind you of what I mean. So I think in terms of utility, my argument that heart-only transplant is better is the right one. So I'm going to come to the next one. So Fontan-associated liver disease is a pathway to perioperative catastrophe, and doing the same thing over and again and expecting different results is insanity. Okay, so it's true that bleeding is an important cause of post-operative mortality. I 100% agree with that post-transplant, but I think the situation of what kills patients in the first phase of transplant is very much more complex, especially if you think about the patients we're talking about. So there are so many different types of Fontan circulation. All these different versions of it. We've heard about the history of the surgery today, and it's a wonderful story of innovation and impressive survival improvements. But it means that there are lots of different sorts of patients out there, and there are different patients even from the original anatomy with which ventricle is first and last. So these patients they probably all respond slightly differently to the surgery that we put them through. There's also differences in the liver. We heard that there can be other, like fatty livers and patients who have exposure to toxins and alcohols and with hepatocellular carcinoma and without, and where the liver is. And these things make a difference, I think, in how patients do post-transplant. None of this, I think, probably is as big as this in terms of, my argument really would be that this is a huge part of how we manage transplants and how we get good outcomes. Every place that does transplants does them differently, does them with different teams, different people, and who runs the show is different in different places, and who's at the center of the decision making. And your transplant can be done by an adult cardiac surgeon, a congenital cardiac surgeon, a pediatric person who primarily does pediatric procedures, and the anaesthetists are all different, and who manages your ICU are different. And then who puts the patient on the waiting list, and who picks the donors. All of these things are different. I think by no way is the case clear that the post-operative bleeding problem, which kills patients perioperatively post-heart transplant, is caused by the liver. I think some of these things might play a role, which are difficult to factor into it. So I would say that this argument is important, but you haven't proven that it's the heart transplant alone that causes this. I think there's lots of other things, and I think there's a question about causality. And I'll just come back to that in a second, because I'm going to talk to this difficult argument here now. I'm going to use the rest of my time to just talk about this. It's a hard case to argue with this data, you would think, except it's not really. So this, you'll see here, I've changed the graph. This is the actual survival, not for just the ones with Fontan-associated liver disease. This is for the whole group of patients who were propensity matched. So they had 30. When the big numbers of patients that they had, 191, if you work that out, it's a 26-year study with 131 131 patients in 15 centers. That means that if every center were doing them, both types of transplants, each center would do one every 3 years. So the real problem with this data is that there's hardly any patients getting transplanted. No matter what way you look at it, it's back to that utility question. It's difficult to get these patients transplanted. And the real numbers here at risk in this propensity match thing are about 30. So there's not very many patients in this. And I think that they're missing a lot of heart transplant-only patients by getting a multi-center data from different centers in the US that do very few heart transplants. And I'll explain why in a second. We had Ed Hickey showed the data from Toronto, which I'm not going to show, but to show that we had a problem in Toronto with outcomes from heart transplant before 2012. And that was for all congenital patients, but it was definitely worse for Fontan patients. And we had 4 deaths in Fontan heart transplants alone. And we really made a big effort in 2012, 2013 to change things. We actually went to this center, which is the largest center, 31 Fontan heart-only transplants who are not in that data, but it's the same as all the heart-only transplants, to see how they did it and see how they were trying to get these patients with the excellent mortality. So our whole team, a large team from Toronto, visited the Freeman in 2014, but we'd already made some changes. We made the changes in 2013, and I've just listed them here, but we did lots and lots of different things. We started an ACHD heart failure clinic. We put the ACHD cardiologist kind of quarterback in the whole thing, the transplant assessment, the timing of listing, whether there were alternative strategies that could be pursued. We had a preoperative anesthesia clinic, monthly surgical performance rounds, congenital heart disease surgeon performing all the transplants, lots of different things. And we also put a VAS cath in every patient. I forgot to put this on this list, but so that we can do early postoperative dialysis, which somebody else mentioned just before. So we did lots of things, and we really changed our outcomes. So this is our data now in the current era for heart-only transplant. Since 2013, we've done 21 adult heart transplants. 20 were in patients who were on milrinone at the time of heart transplant, and the survival to discharge was 19 out of 21. These are all in Fontan patients, and only heart only. And our 1-year survival is 85%, and we have one person who's yet to reach the year, but she is still alive, and that would be 86%. I have to thank Chris Broder, who's currently in Houston, for collecting this data for us. So we think that we can get excellent results with heart-only transplant in these patients, many of whom have ascites and hepatic, all the features of Fontan-associated liver disease, and we're in the process of writing this up. We did already write up what happens to the liver later on to answer that question about, do these patients go on to get cirrhosis? Do they go on to get other complications of hepatic failure later on? And we wanted to see what happened. This was a while ago. We've obviously done more since then, to the patients who had already survived 1 year. And these were the questions that we were asking. We looked at the pre-transplant clinical characteristics, and you can see that we didn't really do that many biopsies. That's not part of our routine practice anymore, but the ones who had a biopsy mostly had cirrhosis. 80% of them had cirrhosis on liver ultrasound. Many of them had ascites pre-transplant. So they have Fontan-associated liver disease, as we would expect for the ages of the patients. You can see the age at transplant here is quite old, quite a lot older than other people's patients sometimes are in these studies. At a follow-up of 4.7 years, 9 of 10 of these patients had ongoing freedom from ascites. The CVP decreased at transplant and remained normal thereafter, although the liver and spleen dimensions did not change, and you can still see the liver's abnormal. However, with this short, relatively short follow-up, none had developed hepatocellular carcinoma, and the thrombocytopenia had improved. So I would say it's not that hard to argue with this data. Our data's in this data, but it isn't separated out between 2013 and 2000 and before 2013. And though they looked after 2000, I think there's quite reasonable data to say that it really outcomes from heart-only transplant improved in the mid-2000s. I think that there's not a lot of patients in this. It's very interesting data, it's very important data, but it's not a definitive argument, I would say, in terms of saying that combined heart-liver transplant is always better. So I would question the efficacy. So to summarize my arguments at the end of this, I would say that heart-alone transplant is clearly the best option for Fontan circulatory failure. And I would say it's a deliverable and sensible use of organs. The liver can go to someone who actually needs it. You can get excellent outcomes in specialized centers, and I think it's a lot to do with the team and how the team work together to produce an excellent outcome for these patients. It's not easy. I think that there is potential, if you just do the hearts, to scale that for the size of the Fontan population, particularly if you can use VADs to support people till they get transplant. And I'm going to give a 2-minute rebuttal. So, you said it's rarely needed. What did you mean by that? Sorry, it's the end of the day. I thought I would try to entertain everybody a little bit. When would Toronto opt for a combined heart liver? Well, this is when we would. So we would transplant somebody's heart and liver, and we've done it once if somebody who had hepatocellular carcinoma, or if in this picture here you can see the ascites in this liver, but the liver's very small and shrunken, and we haven't determined exactly what small is, or if there were many other risk factors that we felt that the liver being very borderline would be too much, so we would add up all the risk factors. So this would be a case like that. I'm just going to show you in the last minute. Recently, we had a 23-year-old about 14 months ago this was, with severe Fontan circulatory failure. She had dextrocardia, as you can see, left atrial isomerism, bilateral SVCs, and she'd had a Kawashima type Fontan with a right-sided Glen. And she had a Gore-Tex, a 20-millimeter Gore-Tex conduit incorporating hepatic veins. It was interesting, she had these 2 very large hepatic veins. And she had a lot of vena-venous collaterals, and her saturations were 86%. this is just some pictures to show you, and the risk of sternal re-entry, which we take a lot of consideration about. So she had ultrasound and CT features of cirrhosis with portal hypertension, splenomegaly. She'd had ascites for 2 years with paracentesis every 4 to 6 months. We don't generally do paracentesis, which is why I wonder about that as an inclusion criteria. We just don't do it very much, even with big ascites. But she was getting 2 to 3 liters drained out. She'd had prior varices, banded, thrombocytopenia, a transhepatic gradient. So we thought this was a high-risk sternal re-entry, something unusual there about those hepatic veins that might be difficult to plumb back into a new heart. Clearly a massive liver, ascites, and yes, you would think we would do a heart liver. But we didn't. She had just a heart as well, and she was completely fine. And the reason we didn't was we had a meeting with various people, including those people in Newcastle with the 31, looking at all the anatomy, discussing it with the liver surgeons, and we thought of a very thought-through strategy of how we would manage her anatomy, the donor, her risks preoperatively, and she has been fine. She's about 14, 15 months post-transplant now. So really my sort of coffee shop consensus is that there are advanced therapies, and you can't adapt a one-size-fits-all approach, and it's not really one type of patient that you have to do this, and each institution is going to get best results doing it in slightly different ways, and for some places, combined heart-liver might be the best answer, because at least these patients then get a transplant, and they might not otherwise. And different countries might have different approaches, depending on organ availability and that kind of thing. But what everywhere needs is this kind of highly committed, mutually trusting team who can, and you need to be in an institution that can tolerate the learning curve. Even after we revised our approach, the first patient died, and it would have been very stressful if we'd have then had to stop, but we obviously didn't. And I would say that we will always offer heart liver for hepatocellular carcinoma, and these things would definitely raise red flags in us to make us think about it, particularly if there were other anatomical or non-cardiac risk factors that might make us think about it. So I'd like to thank everyone for bearing with me with my cardigan off, cardigan on approach. Thank you for listening. Thank you for the invitation. And I'm really sorry, but I have to run to get a plane, so I'm not going to be able to sit on the panel. But if anybody wants to email me or talk to me afterwards, you're welcome. Thank you very much.